Sorry. Sorry. There we go. There's the
Did
dot.
everybody else?
Yeah,
Oh, I thought it was me. I thought, oh no, I'm kicked out.
it was me. I saw someone was going to the wrong meeting and I was trying to save them and send them here and I cut this one off by mistake.
Oh,
Oh
okay.
goodness. So
I
all
thought
right.
it was me.
No, so no, just to finish what I was saying, so you just have to be very attuned to what sometimes, because not everybody understands what you're going through. So you just have to be very attuned to exactly what the doctor thinks is the problem, and if that's what you think the problem is.
So I don't know if I'm the only one who got lost here.
Yeah.
I mean, it just disappeared. Everything went off. But is there anything then that helps to help you hold urine instead? Not, I don't have a problem going to the bathroom. I
Yeah.
can't hold it at times.
Yeah.
But is it an implanted thing? I don't mean the pills or the medicines and all that.
Yeah, I mean, we talked about, I don't know if you heard it, I talked about the fillers sometimes can help.
Yes, that's where I lost you,
Um,
right there.
A sling procedure is a type of surgery. Sometimes that can help. I don't know, you'd have to ask the surgeon if they could implant a stimulator specifically for the sphincter to hold. And then when you push the button, basically the sphincter would release. I mean, that would be the ideal situation if there could be something like that, where the stimulation would be actually for the sphincter to hold. The sphincter's baseline is to hold. So like normally in the setting, not in a spinal cord injury, the sphincters are always tight. Otherwise, you'd be leaking all the time. So the question really is it the spinal cord injury that's relaxed the sphincter? Or is it something that sometimes happens over time? It's not unusual for women over time, even relatively young women, to have leakage or incontinence, and then that would be treated differently. Does that make sense?
Does it?
It makes sense. However, I know with my situation, this didn't happen until
Yeah.
the spinal cord injury, number one, and number two, it's not leakage, it's incontinence.
Yeah. So then what you would have to see if the surgeon could put it on the part of the nerve that's for holding. They should be able to tell with the urodynamics, like if they have the thing in there, if they stimulate the nerve, then they should feel the squeeze at the level of the sphincter, and then they can implant based on that.
But again, it's trial and error, correct?
A little
It's not
bit.
like-
Yeah. They won't, I mean, they have to stimulate the nerve to know where it goes. So in that sense, it's trial and error.
I mean, that's why they're called medical practices.
Thank you, Dr. E.
Yeah.
Well, while we're on urological things, someone asked, I have a Mitronoff. Do you want to explain what it is, or should I? Or...
You can explain what it is, Natalia. I've been talking a lot.
Okay, cool. Let me tell me. All right, this is a good test. Okay, so I have a Mitronoff procedure because when I was first injured, I was incontinent, and so I had an indwelling catheter for 3 years, and so my bladder basically became a tube. And in order to augment it, they took a piece of my bowel, the ileum, to be specific, and they clamshelled my bladder and kind of just slapped it on there. And now my bladder can hold 1,000, 1,500. It shouldn't. I'm sorry, it happens. But that's amazing. It was holding 55 cc's and it holds 1,500 now. And then they form a conduit with your appendix from that newly augmented bladder to your umbilicus, and they form a stoma. And so now I can use catheter bags myself, and I'm a quad. I have dexterity issues, but I can catheterize myself through that stoma. And I do that 4 times a day with these. It's super easy to use. And so I love it. I don't have leakage issues. I love it. It works great. So the question was, someone is having pain when inserting the catheter through the stoma. I experience pain that way when I have a UTI, but this person is saying that they have that pain all the time. The urologist is saying not to worry about it, and they want your opinion on it. 1, how did I do? Then 2, answer the question.
You did very well. You did a good job.
Thank you.
So the first thing I'd worry about is a UTI or some type of infection in the area, right? Oftentimes there'd be redness, or the pain would like come out of nowhere or get worse. So if in the setting of no infection, the next question I'd ask is it getting harder to cath? Because sometimes what can happen is the stoma can shrink a little over time, or you can get like stenosis or stricture.
Mm.
So then passing of the catheter would become more difficult, or you might feel resistance. That would be one thing. I mean, if you have sensitivity, if you have sensation in that area, you might always have a little discomfort. I mean, what can you do? You can lube the catheter with like sterile lube. You can try a smaller catheter, things like that. Um, Probably, I mean, for a stricture, they can maybe something they can do, but if there's no stricture and there's no infection, um, and the pain is ongoing, like from the beginning, I can't imagine that any surgeon would go digging or do anything. Um, so one thing that I mean, one thing you could try is putting a little lidocaine jelly like at the entrance of the stoma to start, letting it sit 5 minutes or so, and then hopefully you'd be numb for the actual catheterization.
That makes sense. If somebody had the narrowing or the stenosis, though, that'd be seen in a urodynamics, right?
Not necessarily. You might need a camera to see that.
Oh, okay. Okay. All right. Um, question. There was a question about there's a question about the side effects of Dulcolax and lactulose, other than the obvious.
Yeah, I mean, I don't know that there's a side effect of you mean Dulcolax pill or suppository or
So,
both? The pill, I mean, I don't know that there's much side effects of the Dulcolax pill. It's a laxative. So, and the way that it works is it irritates your colon to cause it to spasm and contract to help the stool move through. So sometimes people get discomfort, pain, crampy feelings. If they're gassy, it can be very painful. So, if you're really, really constipated, you have a lot of really hard stool, and you take the bicycodal, it may not work because it's just causing, imagine like an empty sausage casing, and you have like a lot of hard rocks in there and you squeeze it, like those rocks aren't going anywhere. So they need to be either soft enough to be moved when you squeeze it or like in a slip and slide or something like that. So something to think about. The lactulose, um, it can affect if you take too much of it, can affect your potassium and some of your other electrolytes. So if it's something that you use too much of, you might see that your potassium is low or something else like that. It's actually used in the hospital sometimes when somebody has a high potassium. Sometimes they're given meds now we use different meds, but it used to be we would give them lactulose or something like that. So it is a very strong laxative. It will make you go unless your bowels are particularly slow. Um, but again, I don't think it's anything in terms of like, I guess you could always be allergic to a medication, but in terms of like like if some medicines you take, like side effects, common side effects are like indigestion, uh, change in mood, headache. Like you wouldn't get anything like that with these. Not like those commercials you see on TV. These would just be like, I would call them adverse effects of what the medication is supposed to do, as opposed to like a side effect which is not intended. Does that make sense?
yeah, I understand.
I have a question, Natalie.
Go on ahead.
Right, okay. So I'm a paraplegic and I have a suprapubic indwelling catheter in my bladder because I cannot figure out how to cath. So what are the advantages and disadvantages of having that as long term?
So let's talk about the three. So one is catheterization, right? So the in and out catheterization. If you're in a situation where you're not able to empty fully, it's important to understand that the reason. So let me take a bigger step back. From a bowel perspective, we care about bowel routines because we don't want to just be pooping any old time if we can avoid it. Because then if we want to go out for lunch or whatever, we don't want to have to worry about that. In theory, if you're sitting in stool, you could cause skin breakdown, but your body will poop. You might get it constipated here and there, but for the most part, you will poop and it won't be dangerous. It's mostly a lifestyle issue. Urine is different. That urine has to come out, or you could get kidney failure. So before, I don't know if it was, I think World War I, the number one cause of death in people with spinal cord injury was kidney failure, because it wasn't understood that, because if you wait long enough, you'll leak a little bit. So it wasn't understood that people weren't emptying well enough. So just to put that into context. So it's important to cath if you're not emptying. If you're in a situation where you're not emptying, there are 3 options. Well, really 2, and then one is split. One is in and out catheterization, and the other is an indwelling catheter that stays in.
Right.
In and out catheterization, when done correctly and always sterile, which is hard to do, right? If you're in a public restroom, you got to pull your pants down, all this stuff. But when done correctly, gives you a little bit less risk of infection. So that's the benefit. The other benefit is you don't have to be attached to a bag. Some people mind that and some people don't. The negative is you have to be able to actually perform it. It can be very difficult depending on your hand function or your anatomy. It's not like if you're a woman, it's different than if you're a man. The thing's just right there and you can see the hole and stick it in, but that's not always the case. If you're a woman, you might have to find it. The angle may be hard to achieve. So you may have to adjust how you're sitting in your wheelchair to get to it. So it can become impractical, right? If it's hard for you to pull your pants down, bring your pants up, like all those things, then it can become very difficult. So it's less, depending on your situation, it can be harder to manage. Now, for an indwelling catheter, it's a lot easier to manage. You just empty the bag, and that's it. Every now and then, once a month or whatever it is, you have the catheter changed. A nurse can come to your home, or you can go to the urologist. Between the Foley and the suprapubic, if somebody's going to be with the Foley for a longer term, I usually will tell them to go with the suprapubic because the Foley can make your urethra larger over time. So if there came a time when you didn't need to catheterize anymore and you were peeing, the urethra would be so big that you wouldn't be able to hold your pee in, and that would have to get fixed. The other thing is if you want to be intimate, in the Foley's there, that can get in the way of certain intimate acts that you may want to perform. So the suprapubic solves those 2 problems. The thing about the suprapubic and the Foley is you're at risk of infection more than you would be otherwise. But if you keep the area clean, and some people take things like D-mannose or different like vitamin supplements, and people do okay. But it would be unusual for you to go like years and years without a UTI at least once. The other thing that you have to do if you have an indwelling catheter, actually you have to do it no matter what. You have to go to the urologist. But the thing that the urologist must do if you have an indwelling catheter is every 5 years, they have to put a camera in your bladder because you're at a very minimal, but not 0% increased risk of bladder cancer. So it has to be monitored. When caught early, the cancer is 100% curable. But if you ignore it and it's caught late, then you could get into big problems. So every 5 years, you'd have to have the camera look in your bladder.
Okay. I have very good urologist, so he's always on top of things. So far I have no problems with anything. And I usually clean it every morning, every night. So we try to keep it clean at all times. And I usually just cover it. I don't have it, during the day I cover it with like the gauze, keep out any sort of dirt or whatever from my underwear or pull-ups, whatever I'm wearing. So.
Okay. All right.
Nice. Thank you.
Thanks, Doc. I want to go back very quickly to the stool stuff. So, okay, I know that bisacodyl is a stimulant. You're saying that Dulcolox is Colace, or Dulcolox is bisacodyl?
Yes.
Right. Okay, and then Colace is the stool softener.
Correct.
What is Senna? Laxative.
Senna is a laxative. It's a plant-derived laxative. So that Colace is the only medication, and people, there's actually, if you look at the research, there's some research suggesting that people think that Colace doesn't work so well, but Colace is the only thing that is like a pure stool softener that does nothing else. That and drinking water. So every other stool softener is also a laxative. So like Miralax can soften the stool, but it's a laxative. Lactulose can soften the stool, but it's a laxative. So that you can get, like, if you take too much, you can get diarrhea, you can have accidents. And so that's why with the Miralax powder is hard. It's like, do I take the whole thing? Do I take a quarter? It depends. If I have Indian food tonight, I may not need any, right? So you have to figure that stuff out, and you have to learn your body that way. There are other things that people sometimes try, like you know, adjusting your diet to have a certain amount of vegetables or fruit, prunes. There's this thing called, I'm going to put it in the chat, Cáscara Sagrada, which is, I think translates to like a sacred shell, but it's like, it's also like a naturally derived laxative. So some people use that if they don't want, some people don't like any kind of prescription. So sometimes I'll suggest that if they want to do something else.
So I see why people say that the Colace doesn't work as much because it doesn't have the laxative component. It's not going to be as.
Yeah, it's only a softener. So it softens that stool in the sausage casing, but you still need the casing to be squeezed.
Yeah. Are you of the school of thinking? Now I am, well, I am a doctor today. I forgot. But I theorize that if my bowel is inactive, and I know it's not completely inactive, and I load it up with a bunch of fiber, I feel like could that not cause blockage more than, because we don't have the peristalsis that's pushing the fiber through, right? So if I load myself up with fiber, could I not be blocking myself?
Yes and no. If you do too much fiber, yes, you will get constipated, but you all need a certain amount of fiber to keep yourself moving. So I know it's complicated. So the fiber will bulk the stools, but it will also keep the colon kind of like healthy to keep things moving. So what I will do, so some people need the stools to be bulked. And so like, because some people have spinal cord injury and no spasm, right? So just for the purposes of this conversation, you could have sphincters that are just loose and open. So if you have, that happens sometimes. So if you have an open sphincter, anal sphincter, and you have stool that's soft, it's gonna, no matter how good you are at the bowel routine, every time you bend over, every time you put effort in, some will leak out because it's kind of like bearing down. So for people in that situation, we usually give them more fiber than they need to bulk the stools to a point where they really have to do a bowel routine to get them out. A little fiber is important. And so you just have to, everyone is different. There's not like I can tell you like, oh, you have a C7, you need like 2 cups of this, and you have a T, whatever, you need this. There's a lot of variation. And just like there isn't like people that don't have spinal cord injury, some people poop once a week, some people poop twice a day. You know, it's like, you know, that's one thing that you know, is a little, it's not perfect, and it never has been, no matter what the diagnosis. I will tell you that I don't think it's important that you have to poop every day unless you have accidents or feel constipated when you don't poop every day. So if you said, I want to do every other day, 3 times a week, I usually will start to make a face at a patient if they say, I want to poop twice a week or less. Usually I say 3 times a week. Maybe you do 3 times a week, 2 times a week, 3 times a week, 2 times a week, as long as you're not having side effects of like constipation, like getting nauseous and a lot of acid reflux and things like that, then it's fine. Like your body's telling you it's okay.
I forgot with the enema. The enema is not a stimulant. How does that work?
The enema is a stimulant.
It is a stimulant.
It's stimulant. So in most people that have a spinal cord injury have innervation through a portion of the large intestine. It's just slowed down. That's why you would poop no matter what. So, because the innervation comes from straight from the brain, a nerve loose straight from the brain. So that nerve would have had to be like cut along with whatever spinal cord injury, which is very, 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 very rare. And I don't think I have any patients in that position, even people that can't move from the neck down. So in that case, most of the laxatives help on top of what motion you already have. The part that doesn't have any innervation after a spinal cord injury usually is the descending or very last part of the colon that feeds into the rectum. That's where a suppository or enema can put most, like it can concentrate the laxative to work just in that space to really squeeze that. So that's why sometimes you'll get the Colace to make the stool soft enough to move, say some Senna to move it through a good chunk of the colon, and then the suppository or the mini enema to get that last big squeeze to get everything out.
Cool. Thank you. keeping in line with diet, we were talking about fiber. We have multiple questions on diet for pressure sores that will not heal. Please don't just say protein and ensures. I hate that.
I mean, protein is important. It's
Can you be more
here's what
specific?
here's
Is there like
yeah.
the red meat better than like tempeh?
No,
I mean,
no, I mean, I think it's usually, I mean, you need to eat the equivalent of like a couple chicken breasts worth of protein a day, which would put you in like the 30 to 40 grams, which is a lot. It's a lot because your body's not smart enough to like figure out where to send the protein. It's not like, hey, you know, like Natalia ate a chicken breast, I'm going to send that straight to her butt, you know. It just kind of does, like it uses things as it needs to. And so you need extra, even more than you would normally need. So
I'm
the
sorry,
most
does it
important,
have to be animal-based protein?
no, it doesn't matter. You could have like beans, whatever. Protein is protein. Um, a lot of people will use Ensure because sometimes after a spinal cord injury, you get full faster. So you can't eat like, you know, a double cheeseburger. It just doesn't fit. So that's why some people use Ensure or something else. There are different things. There's Breeze, which is like a juice. There's a Magic Cup, which is an ice cream. There's Jellos and different things you can use. The protein is important. The most important thing in healing a bed sore is doing pressure reliefs and making sure that the sore is clean. If the sore is not clean, it will not heal in. And if you're not doing pressure reliefs, it will not heal in. So those are the two most important things. And it sounds crazy, but there's a reason that we tell you in bed you have to turn every 2 hours, in the chair you have to adjust every 20 minutes. That's because research has shown that that's the shortest amount of time it can take you to get a bed sore. So most of you on this call are going to be like, yeah, but I went all night and I didn't get a bed sore. I didn't turn. Amazing. Great. But that doesn't mean that you couldn't have, or that the person next to you wouldn't. So when you have the bed sore, the skin has been compromised, and depending on how deep it is, the muscle. And so it's more sensitive than usual. So the pressure release become more essential. And the other thing that happens is there's a shear effect you have to look out for. So like if you imagine like if you're sweaty and you put your back against the wall and you start to lean down, your skin can stick to the wall, and you know what I mean? Can you picture that?
Yeah.
Or like going like this, like my face moves, like my skin moves, but my bones and like the deeper muscles don't. So if you have a shear effect, and all of us have it, if we're sitting and we lean, like there's shear, but when the wound exists, the shear can make the wound worse much faster. And so then that's another reason why the pressure release become important, because you may not even realize you have shear there, but to lift will release that. And then you sit back down straight. So I have found the people whose wounds heal the fastest are those that are most religious about pressure reliefs, even though it really sucks. And I will hear from them daily about how much it sucks, but then the wound heals faster than if they don't do it.
Okay. So okay. All right. The pressure relief is
there are, you can always reach out if you have a physiatrist or a rehab doc, you can always reach out to them. There are usually dietitians, although depending on your insurance, they may or not be covered, but there's also a lot of resources online about this kind of stuff. If you Google like spinal cord injury, pressure sore, like percent of protein and things like that, University of Washington, I think, and there are a few other places that have like a lot of good tips and videos and different things about like doing skin checks, how you should eat, like how you should transfer. Like I had one patient who had a bed sore and they couldn't figure out why. I do all my pressure reliefs, whatever, I'm eating all this protein. And we watched them transfer, and it was because every time they transferred from the wheelchair to the bed, their butt was hitting the wheel on their chair, and they couldn't tell. And so it was just like a hard hit every time, multiple times a day. And so sometimes you don't even realize what could be going on. So also sometimes just getting into therapy or having somebody watch like your daily routine, it may be something because you may not be doing anything wrong that you're aware of. It could be something else that you're not even aware of that's going on.
Okay. How do you feel about people sleeping? Okay, I'm not trying to do all the turning every 2 hours. And so I sleep on my belly. I sleep face down. And I'm not gonna lie though, I do get neck pain and I have hardware in my neck. But in general, because I feel like the other solution is to lay on my back and kind of elevate my legs so that there's no pressure on my tailbone. Are there sleeping positions? Because I'm lazy.
You can sleep in any position, but any position you sleep in, you will have pressure. So like when you're on, if you're face down, the pressure, like straight face down, is forehead, chin, sternum, anterior front portions of your hips, knees. If you're on your back, it's your sacrum, your heels, your shoulder blades, the back of your head. So I'll say this. I understand that turning every 2 hours is not fun. And I have, I don't live your lives if you're somebody that turns, but I have had babies and I know what it feels like to wake up every 2 hours, even if it's for like 30 seconds, it sucks. And over and over and over again. So if you can get through the night, if you have the kind of mattress and whatever, and you've been living that way, I'm not telling you to change it. You should, like, if things are working, and maybe you're just lucky that your skin is okay that way, or whatever, you have a good mattress or whatever it is. But once you have a bed sore, for me, that's an all hands on deck situation, because if it needs to get better, because if it gets worse, they can get worse pretty fast. And if you get down to the bone and all this, it could just take, even if you're doing everything perfect, it's going to take months to heal at that point.
Okay. I want to move on to spasticity. A couple people want to move on to spasticity. Well, this is a two-part question. So I guess I'll start with other than stretching. We know that. What can we do to reduce spasticity, especially when you're a vet in this and you've been taking spasticity drugs for many years and they are no longer effective for you, and the stretching is not sufficient? Or is there different medications than just Pavlovan or that's the question.
Yeah. So I'm going to say something that a little in jest, just to lighten the mood a little bit. There have been studies that show that orgasm helps a lot with spasticity management.
Say less. Ha!
So it can help. The issue is, it only lasts us so long, right? So you might feel good for like an hour or two and then it could come back, but that's enough time to watch a movie. So that's one thing. I would say that stretching is always important, no matter what else is going to work. Other things that might not work, that might work in lieu of or instead of, like medications, electrical stimulation. So like on arm bike or a leg bike with e-stim. The other things that can work is even if you don't have a current goal of walking, standing frame can help. Even if you don't have a current goal of walking, exoskeletons have been shown to help with spasticity. So like the robotic walking. So even if you don't think that's something that's in the cards for you right now, that can help with your spasms. I think something that is easier said than done is just regular stress management. Taking care of your mental health. Any stress on your body, physical, emotional, psychological, is going to affect your spasticity. And so I think that's a big thing that we often ignore, myself included, to mention to patients. So I think that's something that's important. In terms of medications, we are limited. Some of the best medications to control spasms are benzodiazepines, but they are addictive, and over time you will be hooked. So I'd never do that. I may have a patient or two, but that's because they came to me already on them. They refuse to stop. But so I never really start them. If you need them for like an MRI or something, great. But baclofen, tizanidine, dantrolene, which I don't tend to use because it can affect your liver, but it's there. And there are a few others, but they all have the same side effects. They all are kind of hit or miss. There are injectable medicines. If it's just kind of one leg or one joint, say just the knees or my left leg more than my right, sometimes you can get injections like botulinum toxins like Botox, or you can get something called phenol, which can stop the spasms for 3 to 6 months if they're done right and if you respond well. So that would be a non-pill option. And the other thing I'll say is, if you have spasms that have been constant over time, that may just be kind of where you're at. But if you've gone 10 years with no spasms, and all of a sudden you start to have spasms, or even if you don't normally have spasms and they kind of pop up, the first thing that you should be thinking of is what's wrong. Do I have a UTI? Do I have an ingrown toenail I didn't notice? Am I getting appendicitis? Because the first, there could be some stress on your system you're not aware of. If it's none of those things and the spasticity is coming out of nowhere, the next thing I would usually do as a doctor is image your spine just to make sure that nothing has changed there over time. Sometimes scar tissue can develop or different things that can change your spasms. Sometimes that's something that's treatable and sometimes it's not, but if we can find the source of the spasms, it can give you some peace of mind in terms of you knowing what's causing it, and B, perhaps allow us to treat it in a more permanent way, or at least in a more targeted way.
Okay. I think I'm really glad that you brought that up about stress management, because if I do the math, it's only in this very short couple of weeks, like the last 4 weeks, that my spasticity has been off the wall. Like I've never had it. And I also had just started a full-time job. And my head was spinning with so much stress. I don't remember being so stressed in years. And I quit the job. And I tell you what, I feel great today and yesterday. You know what I mean? Like I'm not as spastic. So there really might be something to it. And it's true, whenever I have a UTI, I get more spastic. Yeah, sometimes if things are pinched. So yeah, I'm glad you brought that up about stress management. I think that's a good point to bring up.
Yeah.
The other question about spasticity, me and other people I know here have, as the years go on, we get increased spasticity specifically in the lower part of the back. And so sometimes I'm concerned that, like, I know I have a little bit of scoliosis. Sometimes I'm concerned that, like, maybe my coccyx is like injured, and like, is there some relationship to time with a spinal cord injury or sitting in a wheelchair and increased spasticity in the lower back? And if so, what can we do?
Yes. Usually it's a matter of targeted stretching, which can be really difficult on your own. So you would need somebody to kind of help you with that. Or adjustment in the wheelchair. As we change, any of us, me or any of you, our body changes over time, its shape, its height. And so oftentimes people, even though it could happen in 5 years, or some people keep their wheelchair for 10 or 15 years just because it's working. And so, but they don't go get the back changed or the rest changed. So the cushion, the angle of the cushion. So having a good wheelchair clinic, I think, is important. Understanding that you may need a tune-up every so often. Your body is like any other machine, cars or whatever, any machinery. So you might need a cushion. I think it's normal also for anyone as they age in time to get more back pain and spasm. And so I don't think it's unusual. I agree, everyone goes through it. The way that somebody with a spinal cord injury feels it is different. One thing I have done for some patients is to get them kind of like over the hump, if they're going to PT or before while their wheelchair is getting adjusted and stuff, is give them some of the injections we talked about, like the Botox or something, to the low back to kind of calm those spasms down while we're figuring out something more permanent. Just because if you develop scoliosis as a person with spinal cord injury and the surgeon doesn't think you have a goal to walk, they're not going to do that surgery unless the scoliosis is like clearly affecting your intestines or clearly affecting your breathing or something like that. They just, right or wrong, that's just where that practice is at. So usually we have to find a different solution to figure that out. Whether that's some kind of soft bracing, a change in the contour of the back of your wheelchair, therapy, injections. But I think the important thing is if what's happening is not dangerous, then it's really about you being comfortable. So to some degree, there's not a perfect answer there. It's more about what works for you and what you're willing to try, right? If you said, I'm never going back to PT again, well, that's fine. Then we just have to find another way.
Okay. And with something like that, that's the kind of thing where you could do like localized Botox or baclofen.
Yeah.
Because I've definitely gotten lidocaine down there, and I've tried the
Oh.
spinal stimulator down there, and the pain has continued to just get worse and worse.
Yeah. I mean, the other thing to consider is never to forget that if after a spinal cord injury, pain can be tricky. So if I took a hammer to your toe, Natalia, you might, if you felt it, you might feel numb, tingly, burny. So you might say, hey, doc, my nerve pain's out of whack. But the issue really is that I hammered your toe. So sometimes something can appear a way that it is not. So it might be that if you try things that should work and they don't, that a little step back and like revisiting maybe what's going on here. Is it, I was thinking it was muscle spasms, but could I have like a little disc or something, just to make up an example. I'm not saying that's what's going on. I'm going to answer this one question in the chat about medications, and then I have to run. Talk about meds for spasticity. So I'll run through a couple. There are different pills. Baclofen is the most common one you all will hear about. It is centrally acting, means it acts at the level of the spinal cord. It acts on the GABA B receptors, which are the sister receptors of alcohol. So that's why sometimes if you take too much, you can feel drunk or different things. But it's not the same receptor. It's just kind of like a cousin. So it's an important point because you can withdraw from baclofen the same way you can withdraw from alcohol. When the baclofen works, it works pretty well. But excuse me, a lot of people, either it doesn't quite do enough or the dose they need is so high that they get other side effects and they can't tolerate it. Tizanidine is the same. It acts centrally, but it doesn't act on GABA. So you're not getting the same withdrawal concerns, but all the other side effects are the same. If you look at the research for tizanidine, it shows the same thing, that the doses people need to feel relief are higher than they can tolerate for side effects. Dantrolene is actually quite a good medication for spasms. It doesn't work at the central nervous system. It works at the level of the muscle. But it fell out of favor because a lot of people were getting permanent liver damage. So if you're on it, you have to be getting blood checked a lot. And so a lot of people choose not to do that. And a lot of doctors choose not to do it because they don't want to forget to check the blood work and then somebody's liver is damaged. So there are other meds, Klonopin, and different things people use. They all work centrally. So even though they might affect slightly different receptors, they all have the same side effects, potential side effects: drowsiness, altered mental status, sleep. I said drowsiness, sleepiness, all those things. So it just depends what works for you. It's a bad situation. The meds that are starting to come over from Europe a little bit are like marijuana derived pills. And so some people say that marijuana works for them. Some people are on medical marijuana already for spasms. They used all these things in Europe already, and I know there are companies here trying to get approval. It's a little complicated because they need a federal approval, and the marijuana technically is still not, it's not federally legal. So, but that's another thing that's maybe coming down. The idea there certainly is not to give you any altered mental status with that, but to affect just the spasm. So, so hopefully that answers that question a little bit. There are a lot of options, but no one perfect option.
Have you heard about CBD being effective for spasticity?
Yeah, that's the CBD would be like the marijuana. So marijuana is CBD plus THC.
Without the fun, yeah.
Yeah. So I mean, it can be. Sometimes people get even the CBD like massage oils and have it massaged in. I've heard some people try acupuncture. Some of the stuff we don't fully understand how it works, and it works. Just like if you tell me, "Hey, orange juice works for me," I'll say, "Great." It doesn't matter how it works as long as it's working for you, and it's not dangerous. So there's a lot about spinal cord injury that still we don't know exactly what how or why it works, but it does, or or in some cases it doesn't. And so it can be frustrating because somebody might not be able to give you the perfect answer, but that's probably because we don't know.
Well, I think you've given amazing answers today, as you always do, Doctor. Thank you so much for doing it.
Yeah, it's a pleasure.
Thank you. I really appreciate it. I know everyone here does too.
All right.
Yes.
Thanks, everybody.
Thank you
so much.
Thanks for the
Thank
great
you.
questions.
Thanks for taking the time.
All right.
Thank
everyone.
you.
Take care.
I'm sure we'll do another one soon.
We will.
All right.
Bye.
Bye.
Thank you.
Thanks, Natalia.
You got it.
Thanks, everyone.